Excellent. So, good evening, everybody. We are now live on YouTube. My name is Isabel Germano. I'm the chair of the AANS CNS Joint Section on Tumors. And tonight's event is called Headlines. Dr. Brian Nahed and Susan Panullo are our chairs. And we envisioned this event to be a way to get to know each other. All the panelists tonight are part of the executive committee of the AANS CNS section on tumors. And we felt that there is a lot of talent around the table, and we wanted to give each person the opportunity to tell us a little bit about themselves, and also hopefully to inspire more people to join the field of brain and spine tumor surgery. That being said, Susan and Brian, please take it away.
Thanks so much, Isabel. Thank you to all of our panelists. Thanks for sharing a little bit about yourself and what inspired you to become a tumor surgeon, and also to be part of this amazing community of neurosurgeons focused on tumors, both of the brain and the spine. With that, I'll turn it to Susan. It's welcome to everybody, and to all our folks on YouTube. Thanks for logging in.
Thanks so much, Brian and Isabel. So for those of you who have been on one of these before, they're a lot of fun, very low pressure, and I think everybody's going to have a really good time, and we appreciate you guys spending time with us.
Excellent. So I think the first pair is Matt and Rowan, and you guys will tell me who is introducing whom.
Yeah, no, I think I'll be introducing Rowan.
Exactly. Yep. You got it.
So Dr. Ramakrishna is an associate professor of neurological surgery at Cornell, and Presbyterian in New York. He's the co-director of the Rhodes Center for Glioblastoma, and has recently been appointed as the chief of neurosurgery at Brooklyn Methodist. And he's serving on the guidelines committee on the tumor section. So without further ado.
Yeah, I have a technical problem. I have to apologize. It looks like the whole deck is momentarily.
I can mime my slide.
You can mime your slide. Okay, let me just. Not sure.
Dr. Link can do interpretive dance as well. That's my. Yes.
6 figures or something.
I know that is here, and I really apologize. Let's see, headline. Okay, here it is. Okay, the panic was just to make this real a real thing and not just fake, right? Here we go. I think now you see my my screen, right? Yeah.
Yep.
Okay, awesome. I'm sorry, and you see the circle around Rowan, so we're good. We're in the right audience. Okay, take it from here. Thank you.
Awesome. Well, in terms of my highlights, again, thank you to the AANS, the tumor section for organizing this. That third panel that's blank on the right, that column was supposed to have some research data from some genetics work that we're doing at Cornell, which we're really excited about, but I failed to get slides in time. So we'll concentrate on the first two things. Clinically, my happy place is insular tumors. I really like them in appropriate selected cases. I think it's a fascinating area of the brain to operate in from the standpoint of invoking all the things that I love about neurosurgery, which is microsurgery, brain mapping, using the microscope, all of that, and, using microvascular techniques, all the things I really love in neurosurgery. So it's great when you have terrific outcomes. And I think in those cases, you feel really good. It's one of those high five moments in neurosurgery that we love. And of course, the key to that is just patient selection. So the other happy place for me is phenoorbital tumors. I love operating on the orbit and these multi-compartmental lesions. I just, although I hate herniating periorbital fat, I do love the operating in those types of lesions that occur there, whether it be meningiomas or schwannomas or what have you. Lately, we've been getting a lot of gigantic thyroid metastases that have looked like this. So again, these are the places I really love to operate in. The other thing I'm working on, which is related to neurosurgery, which I'm really excited about, is an app called Rune, which I co-founded with some other gentlemen from Pinterest. And essentially, our goal with Rune was to create the best Q&A experience online, better than Google, for the condition of glioblastoma, and then eventually other brain conditions, and eventually other aspects of health. It's topically organized with video content, etc. We have a number of content experts across neurosurgery, neuro-oncology, etc. And it's meant to be an agenda-free place for patients and caregivers to get answers to questions that come up over the journey of glioblastoma. It's sort of, if you want to know what the app is like, and I encourage you to check it out, it's at rune.care. It's a hybrid of Masterclass and Quora and Reddit, but rolled up into an app that is very user-friendly for patients and families. So something I'm very, very excited about. And then if we go to the next slide, my personal tidbits. So 3 facts, 1 fiction. Which is it? Is it having a third child? That would be a terrible idea. Is it stranded in a cornfield by disgruntled tuk-tuk driver in Laos? Am I a Rocky franchise enthusiast or a motorcycle owner?
Okay, so we actually have 4 this time, and my poll will set up for 3, but that's okay. Can you just guide us out of 1? So 2 are false and 1 is true. Is that right?
3 are true and 1 is false. Sorry.
I see. Okay. All right. So let's have the audience voting for what do they think is false. Just vote in your mind, because I cannot give you a poll because it was set up differently. And now we're going to ask Matt to give us the answer. Matt, what do you think?
I only see two kids there, so I'm going to go with number 1 as the fiction. Is that am I wrong?
Do you want to continue going around purposes, or should I just tell everyone? Is that
you should just tell, yeah.
So the fiction is is number 4, motorcycle owner, though I would love to have a motorcycle like a Ducati Scrambler. My wife has said no to this. I am a huge Rocky franchise enthusiast. That is the Aristotle poetics of our time. It is the ultimate grit story. And I think it is, as classic as it gets. I was stranded in a cornfield by a tuk-tuk driver in 2005. That wasn't pleasant. And I am having a 3rd child. So.
Congratulations.
Thank you. So I'm introducing Matt next. It's my pleasure. So Matt is the director of brain tumor research at Allegheny Health Network Neuroscience Institute and General Hospital. And like me, he's on the executive committee and a member of the guidelines committee. So thanks again, Matt.
Yeah, so thank you, Dr. Germano, for the invitation to being here. So unlike most of the really esteemed panelists who are on the line here, I'm relatively new into my practice, just finishing my fellowship at MD Anderson. Just about like a year and a couple months ago. So really this overview is really kind of things I'm trying to build within our Neuroscience Institute. Currently, one of the things that Dr. Ed Oldfield really ingrained in me when I was a resident at UVA was that in order to be successful in academics and to build a kind of fruitful practice in the future, is that you really have to try to get every single patient who you take care of part of your research program. And that's really what we're trying to do here, and to leverage the volume that we have in order to kind of learn more about patients' tumor biology and how to improve outcomes for them. So the 3 things that we're doing currently, 2 of which we just launched this month. First is we've just launched a prospective brain tumor registry. This is kind of modeled after the MD Anderson model, but really trying to collect in real time all of the patient information and morbidity, mortality, as well as tumor-specific, outcomes data, progression-free, and overall survival of every single patient that we operate on, so that we can learn from every single patient that comes to our operating room. Secondarily is extending kind of our understanding of the tumor biology, and not just for brain tumors, but also for any tumor of the central nervous system or peripheral nervous system. And this is in conjunction with our Cancer Institute here, We're fortunate that we do have some significant funding for a moonshot initiative. And so currently we're going to be starting to enroll patients with both benign and malignant tumors of the brain and spine into this protocol. So every patient who comes our way is going to not only have their tumor specimens sent for multi-omic sequencing, such as metabolomics, proteomics, next generation sequencing, but we're also going to be having all these patients undergoing serial blood draws, both preoperatively and postoperatively, for up to 16 years after the brain tumor resection. And all of this in collaboration with Google and other sort of predictive analytic, software companies with machine learning and artificial intelligence will hopefully be able to do a real deep dive in all of this, high volume data. The last thing is sort of a little bit independent of tumor biology, but it's, I think as surgeons, we all, realize that there are patients out there who don't do well, and they don't do well not because of the biology of their tumor, but just because of other gestalt parameters of the patient, their morbidity and their frailty. And so how do we improve patient outcomes, especially in the frail population, and how do we move the needle to get patients who, shown here in the little Kaplan-Meier curve. This is just an example of patients undergoing stereotactic radiosurgery at our institution for non-small cell lung cancer, and clearly patients who are more frail or have more medical comorbidities do worse. And that's actually being worked on with Highmark, our parent organization, with claims data to try to figure out exactly what we can do in order to improve patient outcomes with enhanced recovery pathways, which have been really been developed in the surgical oncology field. So that's a little background there. And on to the next more interesting slide is my family, obviously, is the most important thing to me. My wife, Rachel, and my daughter, Natalia. I just have only one so far. So maybe more, we'll see. As some people know, at UVA, we go to New Zealand for a year. So there's 3 things here. So I did 2 of these 3 things while in New Zealand. One of them I did not do. So is it A, bungee jumping in Queenstown. Number 2, landing a ski plane on the Tasman Glacier right outside of Mount Cook, and doing snowshoeing over crevasses of about 1,000 meters deep. Or was it cageless shark diving in the Benga Lagoon in Fiji?
Wow, those are all amazing. Ron, you're on. What do you think?
I do not think you went bungee jumping.
I did not do that. And I would never do either of these things ever again, but for now that I'm actually attending as a resident, it seemed like a good idea, but now I don't know.
It looks like a lot of fun. All the other 2 are really worth good memories, I'm sure.
Yeah, that was fun. That was good.
Excellent. Matt, you're amazing. And thank you so much for sharing all this. And Ron, you were spot on. Who's next?
So our
Kate?
next pair is Brad introducing Kate.
Yeah. Excellent. Yeah. So again, excited to be participating in this. Is a fun webinar. I'm going to be introducing Professor Drummond. She's Director of Neurosurgery at Royal Melbourne Hospital, and she's co-chairs the global committee for the tumor section. So excited to hear what she has to say.
Good morning, everybody. I know it's evening there, it's morning here, but not 3 o'clock in the morning like it usually is for me for these meetings. It's 8 a.m. So it's great. I've got a little pastiche of some of the research that I'm involved in here. I'm a brain tumor surgeon, chiefly glioma and metastasis, but we've got a very active research program here, and particularly in quality of life and also cognition after brain tumor resection. So in the top left, this is just sort of 3 things that we're working on at the moment. So the top left is our research looking at cognitive function after brain tumor resection. And what it actually shows, so the x-axis is a patient's scoring of their own cognitive function, how they feel. You'll notice that some patients, even who've had small meningiomas removed, score themselves as 0 out of 100. Which is interesting. And then on the y-axis, their objective neuropsychological scores, which you can see are within the 1 standard deviation parameters there for most patients. So most patients actually score normally. So we've had a look at this discordance between how patients score themselves and what their actual their objective scores are, and shown that it's largely related to symptom burden, depression, anxiety, fatigue, sleep, etc. And so examining some of those things may well help with our patients' functioning. So I'm obviously right on line with Rowan there, because underneath that is the Brain Tumors Online, which is our platform for survivorship and supportive care of patients with brain tumors, which has 3 pillars: a learn pillar, which is information; a connect pillar, which is a social media online connection group for different groups of brain tumors, young, old, low grade, high grade, etc. Because we've got a big country with a small population, so it's hard for people to get together. And then the third is a toolbox for interventions, such as cognitive behavioural therapy intervention online for sleep or fatigue. And that's been completely co-designed by our patients, not just by us. And that'll go into beta testing at the end of the year. And then on the right is our other objective research as to the real cognitive dysfunction associated with brain tumours. And this is the work of one of my PhD students. She takes peritumoral brain from my brain tumour operations and runs across the road and slices it and puts it into a electrophysiology bath and patches both the glioma cell, patch clamps both the glioma cells and the surrounding neurons. And that just shows that both the excitability at the bottom there in the graph, the excitability and the threshold for firing is much different in patients with high-grade tumours and low-grade tumours. So we've already got some objective evidence that that the glioma changes the brain, and not shown here is also the fact that the brain in the electrical network it affects the glioma and is probably trophic to growth. And my 3 things. So these are things I love to do. That's my dog, Poppy. She's a rescue greyhound. She's the joy of my life. And at the top there is me and my anaesthetist and our respective partners sitting on the edge of Victoria Falls in Zimbabwe. You can swim out into something called a devil pool, and it's the most terrifying thing that I've ever done on my life, especially when they go, oh, just don't go over there, because that's the bit where you might get sucked over the edge of the falls. So just stay over here. So my 2 facts and 1 fiction. I'm studying theology in my spare time. I was actually born in Germany, or I met my partner in a hot air balloon ride in Africa.
All right. Who is going to give it a try? Brad.
All right. I'm going to say the hot air balloon is fiction.
No, sorry. Absolutely true. I was not born in Germany.
Excellent. Ooh.
That was spectacular.
Yeah,
Thank
it was
you,
great.
Dave.
Okay. So I'd like to introduce Brad Zachariah. He's the Associate Professor of Neurosurgery and Otolaryngology, Division Chief of Neuro-Oncology and Skull-Based Surgery at Penn State Health, and Co-Director of Neuro-Oncology at the Penn State Cancer Institute. And he serves on the Education Committee of the Executive of the Tumor Section.
Great. I figured here, I figured we'd be with a lot of really superb kind of researchers and a couple of great skull-based surgeons, and so this is just, I think, an example from a little bit ago of just, I think, the kind of impact that you could have as a tumor surgeon, and they're not always satisfying in this kind of way, but sometimes they are, and the ability to make such a dramatic impact in somebody's life is, I think, one of the great joys and privileges of being a neurosurgeon. And so this is a middle-aged woman who had really had years of slow cognitive decline, personality changes, to the point where she just wasn't the same person, had gained a tremendous amount of weight, really abulic, and had a loving family that really had taken her to multiple people to try to figure out what's going on. And obviously, it's only when she starts having visual dysfunction that she ultimately gets an MRI, which shows a pretty classic, large kind of olfactory groove anterior-cranial base meningioma with a lot of edema. And so this was a picture of her down here. This is actually just a couple weeks post-operative on the off to the left side of the screen. And this is at a 6-month follow-up. And just in that time, she had lost like 60 to 75 pounds and had basically become herself again. And did make me this very nice Christmas ornament here. And so I just think this kind of impact on a clinical, on a personal, on a single patient level is one of the incredible things about being a neurosurgeon. And one of the incredible things about being a tumor neurosurgeon is these are things that affect people's, not just their medical function, but who they are as a human being, who they are to their family and their loved ones, and being able to kind of give that back to somebody is tremendous. So just a little clinical vignette there. So this is my family, my wife and my 2 kids, some of the things I like to do, skiing and mountain biking and working out. And so my fact or fiction. So this is, I once spent a night camped on the rim of an active volcano in the Congo. I was valedictorian of my high school graduating class. And then I proposed to my wife while she was in the dentist getting teeth cleaning.
Hey, that's fun. That's a good list to choose from.
So I'm going to go that you couldn't make up numbers 1 and 3, so 2 is probably false.
That is good. That is the logic of a neurosurgeon, and that is correct. Yeah.
That's great.
Thank you for sharing all that. That was amazing.
All right. Hello, everyone. I have the pleasure of introducing our colleague, Dr. Michael Link. So Dr. Link is the Charles and Ann Johnson Professor of Neurosurgery and in the departments of neurologic surgery and otorhinolaryngology at the Mayo Clinic in Rochester, Minnesota, and on the Section EC as a member of the Skull Base Committee.
Thanks very much, John, and thanks for everyone. It's really a pleasure to be involved in this. And I just wanted to share a graph of something we've looked at. I have to say, over the last couple of years, with everything that's gone on in the United States, I got thinking a lot about contrarian or paradoxical thinking. Is COVID real? Is COVID not real? Who won the 2020 presidential election? There's been a lot of craziness going on. And it occurred to me that in the world of vestibular schwannomas, we've had a little bit of a paradoxical thinking. When I started training, every tumor discovered was treated, mostly operated. Then when radiosurgery really took off, a lot of tumors treated with radiosurgery. And over the last 25 years of my practice, certainly the pendulum swung to where most diagnosed tumors, in fact, in the United States, about 75% of newly diagnosed vestibular schwannomas are observed because of the feeling that many tumors don't grow. But we know these patients weren't born with these tumors. So at some point, the tumor grew to become the tumor that we find on the initial MRI. And patients often ask, okay, you're going to watch it until it gets to what size? And we would often say, we're not going to wait for a typical size. We just want to demonstrate that it's growing. But then we showed that many tumors that grow will actually stop growing for a long period of time. In other words, they have this stultatory growth pattern. So what this graph shows, this is based on 500 tumors that we've operated here at Mayo Clinic. And we wanted to look at what's the critical size for which the outcome we would most want to see changes. Where's the cut point or the break point in getting our optimal outcome? Because if we're going to operate on tumors, we want to take them all out so the patient's cured. We want them to have normal, not near normal, but normal facial nerve function, and we want them to have retained hearing. So what this is showing, this uses this statistic, and I have to give credit to Christine Losey, who's our statistician, who's just brilliant and has the patience of a saint to explain to me all of these statistical analyses. But the C index is basically a statistical test that varies from 0.5 to 1.0, and it's a measure of the predictive ability, indicating the outcome you're looking for. So for instance, if you just look at the bright blue bars, that is looking at what's the likelihood of achieving a subtotal or near total resection, not a gross total resection. And basically that cut point, the best C index is at 17 millimeters. And what that means is, for instance, 53% of 280 tumors greater than 17 millimeters got a subtotal or near total resection, whereas only 8% of 323 tumors that were less than 17 millimeters had a near total or subtotal resection. So 17 millimeters is the cut point. It turns out when you look at immediate House-Brackman greater than 1, it was also 17 millimeters. If you look at most recent facial nerve function, then it was 23 millimeters. But the thing that we found interesting about this is most of the parameters cluster around 14 to 17 millimeters of cerebellopontine angle tumor extension. And I thought it was going to be all over the board. Like I thought hearing would be way down at the low side of size, but there is this kind of clustering, as you can see. We don't wait now for tumors to reach 14 or 17 millimeters before we recommend intervention, but we are willing to tolerate some degree of tumor growth. In other words, a tumor that's 5 millimeters in the CP angle, it turns out if it grows to 8 or 9 or 10 millimeters in the CP angle, our surgical outcome at least is going to be the same. So we can tolerate a little bit of tumor growth. So that's kind of been our latest thing that we've been thinking about here. I'm not sure that we've distilled it down to a strong recommendation, but I thought the data was interesting. And so these are my personal tidbits. The sailing season in Rochester, Minnesota is painfully short. In fact, yesterday I took the sails off the boat and got ready to haul out. But that's what we like to do. We like to go to Lake Pepin, which is actually where the Mississippi River gets really wide. It's about a 30-minute drive from our house. So there we are, me and my first mate, Stanley, who turns out doesn't really like sailing that much, but I make him go anyway. And so the 2 facts and 1 fiction. So I grew up on a farm and a cow stepped on my foot and I had to spend all summer in a hospital, and that really spurred my interest in medicine. I once took a motorcycle trip across Europe with Art Garfunkel from Simon and Garfunkel. And my favorite hobby is actually cooking. So John, what do you think?
Oh, this is tough. Wow. You know what? I'm gonna say that number 1 is the fiction, because two is just too fantastic. And so I'm gonna go with 1 as being fiction.
Well, good for you. You're absolutely right. That actually happened to my cousin. So my dad worked in a factory, so I actually grew up in the city, but all my relatives farmed. And one year my cousin and I were out goofing around in the barn and a cow stepped on his foot, and we didn't attend to it, of course. And he got a bad infection. I had to spend all summer in the hospital. And I remember going to visit him and seeing the doctors come in, and they were discussing about what they needed to do. And I just thought, wow, that is impressive. So in a way, it kind of did spur my interest in medicine. But fortunately, I wasn't the guy who had to spend all summer in the hospital.
That was great, Michael. Thank you. And John, fantastic. You were able to guess it right away.
So it's my pleasure to introduce John Shin. who is Associate Professor of Neurosurgery at the Harvard Medical School. He's the Director of Spine Oncology and Spine Deformity Surgery. He's the Director of the Neurosurgery Spine Network and the Co-Director of the Mass General Brigham Neurosurgery Complex Spine Fellowship. He treats the full spectrum of complex spinal disorders with particular expertise in cervical and lumbar spine deformities, and most pertinent to this audience, spinal tumor surgery. Yeah, take it away, John.
Great. Well, thanks, Mike. And I thought I'd highlight some recent work that we've been doing. And so I think within the context of tumors, a big part of my practice and interest is in the treatment of both primary spinal column tumors, such as chordoma, as well as metastatic tumors. And metastatic tumors is a big part of, I think, what many of us do, whether in the brain or the spine. And something that I've been really passionate about and learning more about and studying is this concept of frailty and body composition, specific to being able to have a better understanding of how we can select patients better for surgery when it comes to spinal metastases, specifically looking at complications after surgery as well as implications for survival. And I think, whether your domain is intracranial brain tumor surgery or spine surgery, we're thinking a lot about frailty. I heard some comments about frailty earlier, and have a lot of different ways of thinking about it. And one thing that I wanted to do was try to take objective information from radiographs and scans that we typically do in patient care and try to see if we can really glean some bioinformatic information from those scans with regards to their outcomes. And so we collaborated with a great data science team here in Boston who developed a machine learning algorithm to extract a number of different body composition parameters from routine CT scans. So CT chest, abdomen, pelvis that you'd normally get for staging scans or for surveillance. And they're able to basically pull out markers of sarcopenia, including skeletal muscle index, visceral fat area, subcutaneous fat area, as well as a skeletal muscle radiodensity. As many of you know, there's a lot of interest in measuring sort of psoas size, volume on CT imaging. And so this is, instead of just sitting at a PACS and marking all this out with your mouse, we attempted to really take that algorithm, which has been externally validated on normal controls, and really apply that to our retrospective cohort. And so that's what we did in this study, which was really the first study looking at this in terms of seeing how this compared in terms of predicting outcomes, survival and complications after spinal metastases surgery. So we looked at our institutional cohort at the MGH and looked at a number of parameters, including BMI and these indicators here. And this was our really first foray. And we discovered that we can sort of see these patterns or clusters of patients based on various characteristics, looking at their various skeletal muscle and visceral fat densities. And so, there's still a lot of questions to be asked. And, we're also looking at this in other domains of spine surgery populations, but within oncology, I think there's great promise because as I think everyone can relate to, patient selection can be very difficult. So just something a little bit about myself. This is my wife, Christina, and my 3 kids, Ben, Lila, and Addison. And this was from a vacation taken earlier this year. And we didn't plan the colors, but it just turned out great. So, but they're obviously wonderful and the most important thing in my life.
Do you want to share 2 facts and 1 fiction that we can pick and choose from?
Yeah, sure. So I would say, so I'll list out 3 things. So one is recently going to the White House with a K-pop group BTS to meet with President Biden to discuss Asian American issues and Asian awareness, especially in the context of Asian hate crimes. The second is I was in a band while a resident in Chicago, and we played a number of gigs and was featured on a local radio show called Local Anesthetic on WXRT. And the next one is my favorite composer and artist is Hans Zimmer.
Oh, boy. I think 1 and 2 sound quite likely. So I'm going to say that's not your favorite composer. I'm going to say 3 is false.
So actually 3 is true. Number 2 is true. Number 1, I appreciate that. That's great. But no, that wasn't me. My younger brother is a mover and shaker in Hollywood, and of the many things that he does, he's part of the management team for BTS. And so they recently went to the White House, and it was a great moment. And it's one of those things where, you know, we take, I think we all have a lot of pride in what do we do. And the day he went to the White House, I was like 2 hours behind in clinic, and it was a real, it was just a great contrast. But thanks, everyone.
Thank you, John. That was great. And Mike, you were put in a very tough situation there. Those were not easy to choose from.
All right, so now we have our last 2 pair, which is Isaac and Paul.
Great. So thank you, everyone, for having me. And just really, this is a lot of fun. Glad to be here with such an esteemed group. It's my pleasure to introduce my friend and my colleague, Dr. Paul Gardner. He's the Peter Janetta Endowed Professor of Neurosurgery. He's a Vice Chair for Surgical Services in the Department of Neurological Surgery. He's the Director at the Cranial-Based Surgery Center at the University of Pittsburgh Medical Center. And he's the CNS Foundation Liaison to AANS Section on Tumors.
Thank you very much. I want to echo enjoyment of being here. This is a great session, and I think now we know who to reach out to when we want to get BTS at the next CNS meeting. We know how to achieve that. You know, one of the great things about the CNS tumor section is you get to see what everyone else is doing and see, you know, it really sets a standard for what I think we should do each in our own little section. And within skull-based surgery, I've tried to apply a lot of molecular concepts. We've seen everything from collaborating with people on RNA sequencing to try to understand chordoma better, to prognostication on it, and even looking at neurocognitive outcomes. So it's wonderful to see other panelists doing some of the same kinds of things. And this is just a recent anatomic paper that we're working on that's in at least in submission. And I don't know if it's possible to play the video there or not, but this is just a Petrous triangle that is able to get us access into the Petrous apex from an endonasal approach, and this triangle between the carotid artery.
Demonstration of the paraclival carotid artery and its relationship to the Petrous apex.
Go over to the right there. The
further mobilization at foramen lacerum allows displacement of the ipsilateral carotid artery. Tumor is now debulked using a.
Would you like me to remove the audio, Paul?
No, that's fine. That's fine. So that's my partner, Dr. Snyderman, and it's just showing a contralateral transmaxillary approach to access a large cholesterol, not a chondrosarcoma through this medial Petrous triangle. And oftentimes, these tumors will really expand this medial Petrous triangle, and it gives us ability to access all the way out to the Petrous apex. And here you can see us getting all the way from the middle fossa down to the jugular foramen simply by working through this triangle. So it's kind of something we figured out over time, but I find incredibly useful over and over again. And of course, different tumors have different relationship here, but it's sort of the latest thing we've been working on, at least in the lab. Next slide. My this is a personal tidbit over here is that the first international trip I've taken, really, or first, I would say big international meeting since COVID was this trip to Israel for the AACNS, the Asian Australasian meeting. And here you can see with some of my partners in my department, Dr. Friedlander and Dr. Okonkwo, as well as the local interventional neurologists there who had a fantastic dinner there. And anyone who hasn't made it to Israel, I strongly recommend it for the food as well as for the history. And 2 facts and 1 fiction. First one is I was born in a town called Niceville. The second one is that I own an extensive collection of exotic cars. And then the third is that I once opened for Willie Nelson. Can't make it too easy on you, Isaac.
That's actually quite hard. I would, if I had the time, I'd like look up Niceville to Google it to see if that actually exists. Willie Nelson, that's going to be hard because I just feel like he's a little outside your time range. And then, the word extensive of exotic cars makes me wonder if that's really true. I got to pick one. So I'm going to say you did not open for Willie Nelson.
So I not correct. I actually in my hometown near my hometown there was a Bob Hope Village, and they would do a concert every year to raise money for it, including Bob Hope. And I was in the college band, and we opened for Willie Nelson. So I actually had his bandana. But anyway, that's probably the highlight of my ever musical career by a long shot. For some reason, there's some sort of rumor that I own the exotic cars, which I can barely keep one car running. So it's definitely not true, although I can certainly appreciate nice cars. So
we're going to have Willie Nelson and BTS at our next.
There you go. There you go. So it's my pleasure to round this out by introducing Isaac Yang. He's a professor at the David Geffen School of Medicine, UCLA, as well as being in the Johnson Comprehensive Cancer Center. He's in the Department of Neurosurgery, Radiation Oncology, and Head and Neck Surgery, which I think shows the extensive range of what he works on. I'm excited to hear what he has to say. He's also Director of Medical Student Education in the Department of Neurosurgery, which is something probably all of us should do more, and I think is a critical role. So take it away, Isaac.
Thanks, Paul. Again, this has been so much fun, and just listening to all the talks and just to be with this panel, and so cool. And it's kind of humbling, one, to go last sucks, but with a last name like Yang, I've grown up being used to it. And two, just to follow all these like amazing talks, like, John's talk on frailty and Dr. Drummond's talk, it's just like, whoa, this is a big deal. And then of course, Brad is the best neurosurgeon ever. And I'm just like, yeah, Brad is the best neurosurgeon ever. So I'm humbled to follow here. And so my tumor highlight is this paper, Journal of Neurosurgery, Meningioma Vascularity Index, the MVI for short. This is the initial preliminary paper that's published, and we're now about to submit the final, more complete series. And we've looked at about 100 patients now, and we just looked at meningiomas. And we wanted to assess, can we determine which meningiomas are ideal for embolization and which ones aren't? Which tumors and which meningiomas are going to lead to a lot of blood loss and require transfusions? And our way of doing this is something called the MVI. And the way we do it is we use computer software. So in 2022, as some people have mentioned, there's a lot of data that can be processed. And so you have to look at all these images and have a volumes and volumes of images processed at high speed by a computer and software. And this software is completely free and open source, not proprietary. I don't have any stock. I don't get any commission. But you get the software and you run it. And what it does is auto segments the meningioma. So it identifies the tumor, but more importantly, it takes all the T2 flow voids and volumetrically analyzes them. So you can assess how vascular the tumor is going to be. And so these are 3 examples from this particular publication, but we have more now. This is a right frontal intraventricular meningioma. Left is posterior atrial. Left is a sphenoid wing meningioma. And then it seems like these are just the complicated ones. This was the initial series, but now we have just regular frontal meningiomas, convexity meningiomas, all of them. And when we put them through the software, we found that there's this thing called the meningioma vascular index. And when you analyze them volumetrically, whether or not the cut point is 2.0 cc's, so if it's over 2 or less than 2, that's going to really determine how vascular your tumor is, how much blood loss you're going to have, whether you should anticipate a blood transfusion. And really what's biggest for me and how it changed my practice, because, I trained at UCSF with Mitch Berger, Mike McDermott, Andy Parsa, Mike Lawton, Nick Barbaro, and it was a very embolization heavy practice. And so when I came to UCLA, Neil Martin hired me, and Neil also embolized a lot. And I just thought, that's where we're going to go. We're going to embolize a lot. And what really this gives me a nuance in my practice is that we now can assess quickly and rapidly what the vascularity of the tumor is going to be. And what we're finding is that if it's above this certain cutoff, above 2, that an embolization is probably worth your while and will decrease your blood loss dramatically. The last thing is that you think it's going to correlate with size. That's where I started this project off, and it actually does not. And I think this, at least anecdotally, confirms what I'm sure everyone on this call can confirm, is that sometimes there are these smaller tumors that just bleed like stink. And conversely, there are these giant, large tumors that you think are just going to be a beast, and actually they're not that vascular. And so independent of tumor volume, the MBI has been found to be an important index. And so that's just my way to contribute, and I think it's a really cool thing to see. Moving on to my personal tidbits, that's my wife and my 3 kids. People have said it's the most important thing. They're everything to me, and I cannot do anything without them. And yes, I have 3 daughters, so that's not even fact or fiction. All right, so my facts, 2 facts and 1 fiction. Here we go. Number 1, my very first job was as an oil fry cook at Kentucky Fried Chicken. Number 2, my U.S. Chess Federation rating for chess tournaments is National Candidate Master. And number 3, my car is a 2011 Honda CR-V with navigation and Bluetooth.
It's a tough one. I know, I know the UC system doesn't pay that well, but I find it hard to believe that you're still driving a Honda CR-V, but very possible there. Oh, this is a tough one. I want you to be a national candidate master. So I'm going to go with that one being correct. And I'm gonna actually say number 1 is false. That your first job was not as an oil fry cook at Kentucky Fried Chicken.
So that's actually false. That actually is my first job. So, I grew up in a small town called Lodi. My dad thought I was growing up too middle class, and he said, go get a job. And I fried chicken in the back at KFC, and it prepared me for neurosurgery, because everything in life is better than being in the back of a fast food joint working hard. And so that really was my first job, and it changed me. Number 2 is, you're right. This is my Honda CR-V 2011. So that is indeed my car. I love it. It does have Bluetooth and navigation. It's fantastic. And so, yeah, I actually had to Google this because I don't know anything about chess. We used to play a lot of chess in my residency. I used to play with like Nader Sanai, Mike Shugru, Ed Chang. We just sit and play chess, and I'm really bad at it, and those guys really liked it. And so I had to Google something, and there really is a class of national candidate master, but that's not me at all. Number 2 is false.
I'm feeling Mike Shugru is a national candidate master.
So thank you for sharing all that, and Paul, thank you for trying to guess. That was pretty hard. Susan, if you're on.
Yep, I'm here. So I'm glad we got everybody, I guess, 12 minutes of free time to spend with their families, cook fried chicken, or whatever you guys want to do, discover a new brain tumor therapy. We all really appreciate you all sharing with us. I think from what I've seen from the programs that have happened till now, people have really developed relationships actually from these interactions, people that they kind of peripherally have known, met, can wave hi to, but now you have insights not only into people's professional interests, but also the even more fascinating underbellies of people's personal lives. So it's really great to get to meet you guys in this interesting and new venue. Thanks to technology, and thanks to Isabel for really doggedly pulling this all together, despite everybody at first going, what? So Isabel, thank you. I know Brian is in some exotic location where it's really noisy, and we might get scared if we hear all the ruckus in the background. So I'll leave you still with 11 minutes of free time to do fun things with. Isabel, anything else you want to do to wrap up?
Yeah, I really wanted to thank you guys. It was really great to see all the fantastic work that you do. I wanted to thank you for all you do for the tumor section. And clearly the section could not be as strong unless without your work and your dedication. And I think that it is important that we get to know each other, because as Dr. Panulo said, I think it's only by knowing one another that we can really form stronger bonds and hopefully greater collaborations. So thank you for your time. Thank you for putting the slides together. And this was really fun.
We'll
Thank
see
you.
everyone in like 3 weeks, and
That's right. Exactly.
Great.
And the next one is October. So we have a date for October 24th for the audience. We circulated that email today.